All right, this meeting is being recorded. Today is September 24th, 2025. This is the second official meeting of the Health Economics Value and Assessment Workgroup. We have a specific plan for today, but before that, Gaurav is going to kick us off. We're just getting an orientation of the work that we have done so far, so that we can continue with the second phase of that is today's agenda.
Yeah, so I'm not sure if everyone was able to see the meeting recap from last week, but there's a YouTube video out. We just went over our vision, mission, OKRs. We went over the reintegration of the cost standards, so what we want to see in the new cost table in version CDM 5.5. We provided all of this to the CDM workgroup as well. 1 second, let me try to find that. I mean, yeah, it's kind of the same stuff. Basically, what Claire responded was that this is going to be a minor version. She was a little mistaken because she thought this was like these are completely new changes, but most of them have already been ratified in 6.0, so not a huge change. But yeah, does anyone have anything that we should add to our recap, or maybe that we want to cover going forward, or anything like that?
I think the last recap, to my knowledge, Gaurav, was we were gonna be giving input into the CDM. That's what I have on my notes up here, specifically on making sure that the variables make sense, breaking down the cost categories. Gautam had mentioned, again, I'm going off memory, so I do apologize, paid, allowed, etc. And then also taking into account the different payer systems across the world and how reimbursements occur. So that's the limited notes I took from last time.
Yeah, we took some of those notes as well. Things that like review and feedback. We have a section about all that. But yeah, that will cover in the meeting today. Those will be that's like the deep dive ETL conventions that we were talking about. We'll talk about exactly what you were talking about, Ram, because that was a huge feedback that we needed. But other than that,
Jack or Gaurav, do you know where the document is that, okay, I think you have sent it to me in a link.
yeah. Yeah, here I can send this too as well.
All right.
But yeah, Ron, we'll do that today.
Yeah. And Gaurav has just shared the slides with me, which I'm moving into OHDSI tenant right now. And then you all should have access to it. Apologies. Today was not the. Now there's something called a day job that we have to all do. Right. Gaurav, do you want to walk through the slides, or would you like me to go through it?
If you can, that would be great.
Okay, great. Ram, do you have a comment?
I was gonna say, like, we can always distribute the responsibility. It shouldn't just fall on one person. So if there's anything we can do to help out to lessen the load, let us know.
Absolutely, absolutely. I'm about to take this screen share. Okay, so these slides were based on a document that Gaurav and I and Jack and a few others kind of brainstormed. So this is a proposal to the OHDSI community about Themis conventions to ETL to the new proposed CDM 5.5. We hope that the CDM workgroup will approve it. And irrespective the table structure, assuming it will go to some version of the CDM, this would be the proposed ETL convention. Again, this is a discussion. So, what we were thinking, one of the fundamental tenets that we want to do is the output that will be calculated by any software, any standardized software running on data that has been ETL'd into the OMOP CDM cost tables would be good enough for actuarial certification. So it has to be precise. And so we put in a lot of thought in this proposal to ensure that, in other words, strict conventions are essential. So a software that will run analytics on OMOP CDM with cost tables should check for conformance. And only if there's conformance, then it should provide the analytics part of it. And so that's one of the principles that we wanted to propose. So you have not only data representation standardization, but you also have to conform to the data ETL conventions. And given those two, we will have an opinionated software that will be potentially actuarial quality. So the foundational principles is all data needs to be standardized, of course. But the meanings of every financial term should be linked to the source system that it was generated, and so we have to anchor it. But source systems have different naming conventions, and so we have to explicitly say what source naming convention means what in the standard system. So and not leaving any ambiguity to the person who's doing the ETL. So these Themis conventions has to be well documented and clear enough that there is no mistakes or room for interpretation that could potentially introduce errors and thus lead to the loss of actuarial confidence. So that's the principles. That's the governing principles of what we're going to talk about. So semantic accuracy is extremely important. So we have to define what cost is. This is the point, Ram, you made. We also need to have terminal provenance. So where did it come from? So we have to have traceability. And we are going to propose that we use we anchor this whole thing around a visit-centric approach. So the software will go to the visit table to the cost table. So that you'll see the structure that we have. The ETL convention should be such that any cost record goes to an event record via a visit record. And that just means that the visit is the center of everything. And that convention is essential for cost, because if we are doing cost and utilization, the utilization metrics is centered around visits. And so that's important. So that's another governing principle that we are introducing. So there are two core principles. This is consistent with OMOP CDM. These are the different elements that we introduced as part of the CDM 5.5 proposal. For semantic accuracy, the representation is in the cost concept ID field, and the provenance is on the cost type concept ID field. The semantic accuracy is the economic meaning of the value of the cost. Is it an allowed amount? Is it a paid amount? Is it a copay? Is it a co-insurance? All of those ideas are comes under the cost concept ID. But because the way let's say the terminologies are different across the world, and the cost concept ID tries to standardize that, we will need to have as clear as possible, unambiguous definitions or descriptions of what it is. So very briefly here, we're showing charge. Charge is the amount the provider is asking for. Doesn't mean that's what they'll get paid. That's what they're asking for. Allowed. Allowed is some sort of the amount that the provider agrees to accept. Now you can ask for something, but you can also agree to accept something because they did some contractual negotiation with somebody who's paying. And paid is actually the amount that they have received, which may be different from the allowed amount. They may receive more, they may receive less. And the term cost in this case is actually their internal cost, that is their expenditure. So what they get is their revenue, and what the cost is their cost. Cost, actually, in economic sense, is what does it take for you to render a service. It does not mean your revenue. Revenue minus cost is your profit. So we anchor on this clear, unambiguous meanings, and in the slides we will go into more details, and we'll try to represent how this is captured in the US system, in the German system, in the UK system, in the Japanese systems, and so on. We have done our best. We are not an expert. This is based on general research and our prior experiences. So as a committee, as a group, please provide your input on these ideas. Terminal provenance is the cost type concept ID. This is defines the data record. Where did this data come from? It has a definition, and the definition that we have put in is the OMOP CDM. So it's a final system. It's not the final system may have been generated with 15 other steps before that may be a black box to whoever gets the data, but that's beyond the scope. It is the final system. What is the final system that is being converted to OMOP? What is it saying? So if it's a licensed data set, most licensed data sets could be a black box to the licensee. How did they aggregate it? Where did they come from? They may not even disclose where it came from. That's a problem we cannot solve. But what we can solve is we know the final system, and we will map the final system to OMOP CDM. And OMOP CDM will thus become an honest broker of the final system. And that's the terminal provenance principle. It must identify the ETL developer's direct source of truth. So that's the ETL developer's direct source of the truth. There is no interpretation, not the upstream cause of the value. So it's a clean separations of concerns, and we where it came from and the classification. We don't know. We're not going to speculate. We're going to take what we got and do one-to-one true mapping. That's the principle of terminal provenance. I alluded to you about the core principle, that is the visit-centric architecture. So all financial transactions recorded in the cost table must be linked to a clinical context. But we are going to essentially to ensure actuarial to meet actuarial standards, we are going to use OMOP almost like a star-like representation with the visit at its center. Every record in the clinical event table, condition occurrence, procedure occurrence, drug exposure, device, all has a visit occurrence ID in it. Visit occurrence ID cannot be null in this new representation for the opinionated approach that we are doing. Now, in the OMOP CDM, with the visit occurrence ID in an event table may be a nullable field, but that's a violation of the opinionated software. And so to do a cost analysis, the visit occurrence ID, visit occurrence table should capture the overall encounter and serve as the center. Of course, the single visit may encompass multiple items, like you can have a lab test, an imaging, a procedure, and drug prescriptions, and those are line items. And that's why we have the visit detail. And so a single visit occurrence ID can have multiple visit detail IDs. And this structure is essential because now you have one-to-one record lineage back to the source of truth, which was the terminal provenance principle. And now we know now we can do services per thousand, ER visits per thousand, admits per thousand, because that's the terminal provenance principle with one-to-one record lineage. We're not summarizing the costs. Sorry, let me rephrase. The summary costs are linked to the visit occurrence ID. The detail costs, the line level costs, are linked to the visit detail ID. For every, the principle is for every visit occurrence ID, there can be 0 or more visit detail ID, but there cannot be a visit detail ID without a visit occurrence ID. So this allows us to capture granularity. Now, I will talk to you how the details, the line level detail, essentially microcosting, is captured in the cost table, and the summary level costs are also captured in the cost table. I know I'm giving a lot of dense information here.
Dalton,
Go ahead.
Quick question. So let's say a patient comes to ED and then he has been in ED for several days, and then he goes to, I don't know, inpatient, outpatient, depending on the situation, right? So each of these visits, these are unique visit occurrences, or will they be within the same visit occurrence but different visit details?
Yeah. So it depends upon the provenance. If the provenance data source has one, let's equate this to a claim system. If you are in the US claim system, depending upon the contractual obligations, those could be multiple independent UB04 billings, or it could be one bill where ER transfer to an hospital is one bill, or it could be two bills, or it could be any different factors, and those are representations of contractual things, because the ER may be a different legal entity compared to the hospital system. So if the terminal system tells you that these are 4 records in a span of time, the ETL convention is not going to aggregate that into a span of dates and make it one record. It's going to capture all of those as independent one-to-one with the terminal source. Now, inside those, in the claim system, you have a header record, which is equivalent to the claims header is now visit occurrence ID, and the claim detail line level information is the visit detail ID. So visit occurrence ID is header, visit detail is line. And if that encounter of a patient falling down, going to the emergency room, getting X-ray, CT scan, getting a decision to be moved to admitted to the hospital, getting a surgery, getting transferred to the rehab, being 3 institutional claims with 25 professional claims, all of those will be independent visit occurrence IDs because they all, and the details of those will be captured as visit detail ID. A similar principle will apply for electronic health record systems. So the electronic health record systems has them as one full encounter, as a date of admission, date of discharge, and everything is one. Then it's one claim header.
Thank you, Gautam. Appreciate that.
That's just the actuarial principle that we are following. It's not the standard OMOP principle. just to, because on the train of thought, the OMOP principle historically has been we are going to aggregate and think from the patient's perspective, and that patient perspective is the date range that they were in the hospital. Inpatient stay is the period of time that the patient slept in the hospital's bed. If they were not in their home, that is a span of dates, and that span of dates will be considered one visit occurrence ID. That is a historical legacy idea. The reason why that idea was implemented was in 2012 and 13. There was two reasons. One, the table size went really big, and the servers that well, at that time, which was mostly steel boxes under people's desk, couldn't handle it. And the other reason was that the software like Atlas, which did not exist at that time, but when it was initially created, did not have a complex SQL logic that collapsed eras in a cohort. So because it couldn't group date ranges into continuous spans of dates, which was a principle of the cohort table, they basically made the decision that do that in the ETL because we can't handle it on the analytics side. But now we can handle it on the analytics side. I put that in 2019. So since 2000, just for this particular problem, to solve this problem. And so Atlas now and OHDSI software does not have a requirement that verification has to be done during ETL. That's just a legacy carry forward from before. Just a history lesson. Apologies for the divergence. So the architectural conventions, we obviously, we discussed it last time. We want to make sure that we are backward compatible. That's a requirement of the OMOP CDM work group, and we have proposed a backward compatible CDM 5.5, but we are modernizing it. And the modernization is essentially being able to represent all these cost categories and using the cost being represented with cost concept ID instead of named costs, that is as columns. The legacy 5.4 has explicit column fields, as we talked about. But our ETL convention is you must, and that's how it's italicized, we must prioritize populating the normalized long form. The normalized structure provides the flexibility required for mapping international and complex use cases. Legacy fields should only be populated if they have some legacy code that has to absolutely run. But unless it's an exception, not the rule, and that exception should be only implemented at risk. So we strongly discourage the use of the legacy fields. The legacy fields will be retained because removing it is a breaking change. Again, it's on opinionated. We're going to say Themis convention, visit architecture and linkage is mandatory. All records in the event domain tables, drug exposure, procedure occurrence, measurement, device exposure, should be linkable to the cost table via the visit. So there is no way to link cost to drug directly. The only way the SQL joins will happen is drug exposure ID will have a visit occurrence ID, which will join to the visit occurrence table, which will join to the drug exposure, the cost table, because the cost table will have a cost event ID. That cost event ID will always be a visit occurrence ID. Does that make sense? Complex SQL, but that's the opinionated software. So it becomes a star representation. Visit occurrence ID is the primary key of the visit occurrence table, and so serves as a central point. And the visit occurrence ID can be joined to multiple domain tables because that's now it's the star, that's the center. And the visit detail will include all the multiple activities that are inside the visit occurrence ID, your blood draws, your physical exams, imaging, drug prescriptions. Depending upon the data source, you'll have a lot of details. And these details can be captured in the visit detail. And in the visit detail table, the visit detail ID is a primary key. But it also has a visit occurrence ID. So if you the visit detail ID. The primary key is a visit detail ID, but it has a foreign key or visit occurrence ID. So visit detail ID can go to the visit occurrence ID because of that structure. And the cost table has a foreign key, which is called as the cost event ID, and it has a cost event concept ID. The combination of the two tells you which foreign key does it have to link to. Is it the visit occurrence ID or the visit detail ID? And also it tells you the cost event concept ID tells you which table field does it go to. And you'll see that in the next slide. So I think this is there's a little bit of repetition in what I'm saying, but just again, it's a discussion. It's a very complex topic. It's pretty dense, and so repetition helps. So all records in the event domain tables and the cost table must link to the visit architecture. The linkage mechanisms, domain event tables contain both visit occurrence ID and the visit detail ID. And here's an interesting point. All the domain tables, procedure table, condition table, drug exposure table has as foreign key visit occurrence ID and visit detail ID. So it is possible to link the drug exposure, line level drug exposure, to the visit detail ID, and then go from visit detail ID to the cost. So we have it there. It is from SQL, it is possible, which is fantastic. The linkage requires joining both the fields. For example, the procedure occurrence record links to the visit detail table by joining the visit occurrence visit occurrence ID to the visit detail visit occurrence ID, and procedure occurrence visit detail ID to visit detail and visit detail ID. So now you have those joins, and then you have satisfied the star schema. So say we talked about the uniqueness of the visit detail again of table. Visit detail is to do the microcosting. Microcosting is the visit detail ID is the primary key. It could go to multiple domains, and there are some exceptions that we thought about, but I think we can handle it when that use case comes. But just wanted to say, visit detail. When we go to microcosting, the world kind of explodes a little bit, but that's there. Cost table structure and linkage. We talked about why this is important, and this slide kind of tells us why that is important. One of the reasons why actuaries and health economics outcomes research don't like OMOP is because OMOP loses. OMOP is a lossy ETL. We lose record level information, and what this one is, it solves that problem. So it retains line level information. But we are not reinterpreting the source of truth, the provenance. If the source of truth says this is a header level data, it goes to, we are calling it a summary cost. Header is called a summary cost. If the source has a line level cost, we are calling it a detail cost. Same idea, just a slightly different name, so that we standardize the name, not just call it US claims names, but a generic global name. So for every record there is a summary, and that in the cost table, the entire visit, the visit occurrence ID, would be linked via the cost event field concept ID through the cost occurrence, and there will be a specific cost type concept ID to say whether this is a summary or detail, I believe. Now, here's the caveat. Because of the way this is designed, And this cost table is a very long entity attribute value table. The cost table is going to be long, and it's because it captures a lot of detail. So the structure of the cost table is designed to be extremely long and granular. And the ETL folks are going to complain about it being that because it is going to be the largest table in the OMOP CDM. That's the nature of this field. So it contains one row for every record in the visit occurrence table that has cost information, and one row for every record in the visit detail table that has cost information. So now it is a combination of visit occurrence and visit detail, making it a large, long table. Something that we have to explicitly say up front, but that is the architectural convention. We need that architectural convention to make it work. Otherwise, we're losing information. And if there's a pushback from anybody, this is big data. It is big data. So cost domain specific modeling. So let's talk about drug records. So drug is an interesting domain because you can make the argument that clinically, just picking a drug from a pharmacy is not a visit. Not actually seeing a doctor, or receiving a mail order drug is not a visit. That's true. And the OMOP CDM's visit idea is based on the patient's perspective. But here we are not thinking about it that way because we're doing health economics and outcomes research. So in this case, every drug exposure table has a visit ID. Even if the patient did not see a doctor, there is a visit ID. There is a visit ID, and that visit ID, visit occurrence ID, and that will be represented by a visit concept ID. And that visit concept ID will basically say it's a pharmacy visit or some form of a pharmacy visit. And we have things. So what does it say? Drugs can be prescriptions, drugs can be dispensations. Drug prescriptions will have a visit concept ID that represents prescriptions. Drug dispensations will have a visit concept ID that represents whether this is a mail order. Did the patient receive it via mail? Did they receive it in store? Whether this was a barcode administration, whether it was directly observed therapies, all of those will have concept IDs, and we're going to show you those concept IDs, and that will be part of the ETL conventions. But the key here is every drug exposure table will also have a visit occurrence record. So now you are blowing up the visit occurrence table also, because the visit occurrence table has all the records of the drug exposure. And they're blowing up the cost table because the cost table has visit. So it's going to be large. The drug type concept ID field in the drug exposure table must be able to differentiate between prescriptions of the various types of dispensations using the OMOP type concept, and we'll show you that. The OMOP vocabulary concept IDs will give you a concept ID, it's already there, that tells you whether this is a line level or a summary level. And that is a concept class ID in the OMOP vocabulary. So ETL conventions will describe those. Here is another architectural principle that we will introduce. Because when we sum up costs, and if we sum up costs across cost concepts and cost type concepts, it can create double counting erroneously, because most analysts would not have clear understanding how the ETL was done. We are not doing aggregation during ETL. And that's again back to the provenance principle. Do not aggregate or summarize cost during ETL. If the source data provides components of payment, example, payer paid, deductible, copay, each component must be mapped to the specific concept ID as is. There is no summarization during ETL. There is no group by sum of in ETL. There is something called a calculated field that we might give an exception for. I want to discourage the use of calculated field, but at the end of the day, ETLers should not do calculations. The source data, the terminal provenance, should do the calculations. That's what, so there is one rare exception that we may have to think about. That's unclear, but for now, the recommendation is no aggregation, no calculations by ETL. So it's a terminal provenance. All right, that's the structure. That's the mapping logic. I'm now going to go into mapping concept IDs. Any questions so far?
Hey, Gautam, I just put a really quick comment on TPLS, third-party liability. A very small example of it is I get hit by a car, someone else has to cover it. It shows the negative dollar amount within the claim. So I just wanted to highlight that one small thing. And then also member contributions, that's copay deductibles. I'm sure you're covering that, but just something to think about, like as well.
Yep. Yeah. Yeah, let's think about it a little bit. I'm looking at the comments now before I go to this. So I felt like I'm doing a lecture. I'm honestly not trying to do a lecture here. This is supposed to be a group discussion. So let's take a pause here, and let's read through the post. Okay, Shishir, I hope so. Thank you for the question. I hope the discussion that we had answered it. Do you have any further thoughts on that topic?
Yeah, I think this is good. In terms of ETL, it makes sense, like, because I do mostly the research aspects, and then I'm like stuck with like tracking the patient from their entry to exit. And then I have to like summarize each of these like rigid occurrence ID, and I create my own episode ID for every patient. That's like, I'm basically looking at the patient, like how their, like different condition occurrence, like builds up, or what kind of measurement we take across different time period. So it has always given me like a little bit tricky time, because I need to develop an episode ID. And sometimes what happens, a patient is there and leaves the hospital maybe like, a day or so, not even like 24 hours, come back, right? It has two different occurrence ID, but in my stamp, like I'm basically have to track how that patient developed different types of conditions, the kind of create a temporal mapping of that, and it gives me a little bit trouble. But that's again most like this is a research aspect, not the ETL aspect.
Yeah, and I think you're getting into the episode of care kind of ideas, where you have an episode of care could come back tomorrow. Let's get you admitted. Oh, you had a complications and you went to the emergency room. Oh, it's all part of a series of things that had to have happened to a patient from the time that their condition started to their full recovery, right? And that could be considered an episode of care, and that episode of care could have multiple visits and encounters, and the logic for it is on the analytics side, I would believe, not the ETL side.
Yes. And sometimes there are like different hospitals in different states, and some qualify for Medicaid and some may not. And then it creates like, even the ETL gives us a very standardized way of doing things. But when I get to the research part, I have to like take a pause and like see how things are happening on that particular hospital or on that particular state. And that is more like a research aspect, not the ETL aspect. But thank you for your clarification here.
Absolutely. And Shishir, thank you for coming to the OHDSI phenotype work group and your post there. Okay.
Thank you so much. Yeah, I'm I'm a health economist, but somehow I get to this phenotyping because I had a chance to work with some physician and nurse, and and I get to learn the clustering and like finding variables and all these things. So may not be the clinical expert, but if there is a clinical expert who can tell me, oh, these are the things, then I can pretty much promptly do the data part and research part.
Yep, absolutely. All right. Okay, now we're going to try to cover Ram's points. So third-party liability and member contributions, co-pays, and deductible, and how to model those, and also how to model that not just in the US but across the world. This is the if I were to say summarize what we did so far, although very dense, is actually the easy part. Now's the complex part. All right, charged. Let me walk you through the set of slides very quickly. So the way we did this is we have a series of slides that follows a very similar structure, and that involves a very prescriptive way of saying, if you think this is charged, you're basing it on some idea. And if it's detailed, put this concept ID. If it's summary, put this concept ID. So same thing with allowed. This is the concept ID for the detailed, and this is the concept ID for summary. I am pointing to, I'm moving my cursor thinking I'm showing my cursor, but I'm on the wrong screen. All right, so that's the structure here. So what we need,
and then one thing, the non-US, there's like a little warning for charged. If you're in non-US like tariff-based systems, like in Germany, France, UK, or whatever, the national tariff should not be mapped to charged. So keep
because
that
the
in mind.
charged is allowed in that
Yep.
context.
Exactly.
So I think there's a document that will have, make it a OHDSI forum post, and Gaurav, if you have access to it, you could pull that up too. So this is just the abridged version of a very detailed analysis that Gaurav and Jack and I and a few many others did, bringing forward our prior experiences. So it says here, structure-wise, what are the indicators to look for to consider this to be charged, and what are the indicators to look for to consider this to be not charged? Example, if you even believe that this is allowed, paid, or that cost, that is, how much did it actually cost to pay the hospital system to provide care, do not map it to charged, right? That's the exclusion. How do you know it's allowed, paid, or cost? Look at the allowed, paid, or cost of descriptions. And if it matches that, don't map it to charged. How do you know it's charged? Well, they will have words that will say something like gross charge, billed amount, submitted charges. They are in the US, in the CMS 1500, that'll be the box 24 or the box 28, or the UB04, it'll be the form locator 47, and they have descriptions for it. Now, I am not, I have personally have expertise in the US billing systems, but I do not have the expertise to that level of depth in outside the world, outside the US. So we need people to provide input from their perspective. How would they identify something that considered charged? As Gaurav pointed out, we believe that in the European payment system, there is no such thing as charged. Providers are not allowed to charge. They've been told that this is what they get, what they're allowed. So in the European system, we believe there is no such thing as charged, and the charge is just a US in health economics outcomes research, most people know this charge has got really no meaning to it. You take a charge is just an arbitrary number that has been put up by hospital systems. It has got some basis to it. Arbitrary is a very strong word, but it is being used by a multiplier to estimate the cost. Usually there is some multiplier that says in this geographic area, if the charge is $10,000, the cost is probably 15 times lesser or something like that. So there's a multiplication factor that allows you to standardize it and then use that information. But in general, charged is the least valuable of all the financial metrics for health economics outcomes research. Allowed amount. So the allowed amount, what is it not? Charged is not allowed amount. What the payer has paid is not allowed amount, because what the payer has paid is just the third-party liability that Ram has mentioned. Allowed can involve co-pay, co-insurance, and paid amount by the payer. So it has the patient's share. That depends upon their financial agreements and the insurance benefit design. So ideas like deductible, co-pay, co-insurance, they are all part that needs to be combined together in some form to create allowed amount. Now, where is it done? Is it done during ETL? I'm hoping it's always coming from the source of truth. And this is where the exceptions come in, that calculated field that we talked about. What do we do when the source system, the source of truth, does not give you allowed amount, but gives you components and you want allowed amount? Well, we have to think about it and we have to address that. So that is that one exception that I brought up. But what is an allowed amount? It's the negotiated rate. It's called, or it is the eligible expense, or it is the payment allowance, or it is the Medicare approved amount. So those ideas. So we'll have a document that talks about terminologies to look for to consider a cost item, an allowed amount. Paid amount. So again, allowed amount is not paid amount, because allowed amount is what somebody owes. But that doesn't mean they get that money. Many times there is negotiations. So, but even payments has components to it. So the payer may have paid some money, patient may have paid some money, patient may not have paid anything. So what money did the provider actually receive? That's the paid. And the difference between the allowed and paid is kind of a loss. And so it becomes useful from a revenue cost perspective. So there is net paid, total payments. Paid includes the payer's obligations, the third-party payer's obligations, and the patient's obligations. Paid may evolve over time because you may get payment plans, which will say, I'll give you, I might do a monthly payment plan. How do you handle those? And so they may keep on changing. So there is complexities in the paid portion. Cost. Now, cost is what it actually costs a hospital system, a provider, to provide that care. This is not the charged amount. This is not the allowed amount. This is not the paid amount. This is the actual cost. So we have to be extremely cautious when we use the term cost, because when we say cost, it is the cost of delivering care, not the money they receive. So we have to be clear in our use of the word cost, because cost is by itself seems very ambiguous, but that's what it means in this context.
And the cost is typically a derived value, calculating the charged amount by the cost to charge ratio in the US at least.
Mhm.
But in non-US systems, it's direct measures from integrated cost accounting systems, such as the UK National Cost Collection and German INEK, etc.
Yeah.
So basically, cost just won't it won't be there in most systems in the US, unfortunately.
Most of the time, cost is something that won't come from the provenance data sources. They might, but you can also calculate it by using references. So you can have Medicare. You can use every hospital's cost charges, and then have to use that geographic cost to charge ratio, and then calculate the cost for it. If that is the research that you're doing. Patient liability. So patient responsibility depends upon their benefit design. So in most US plans, there is a out-of-pocket max cap. So patient liability is higher in the beginning of the year, and many times it becomes zero at the end of the year. But that is the cost sharing part. And it's the guarantor's responsibility. So guarantor is the person who holds the contract with the hospital for the care of the person. So like a parent is the guarantor for the child, for example. You can calculate it by summing up the deductible, co-payments, and co-insurance components, and get an output of it. And again, we try to avoid calculating it, but sometimes we have to, because not all of these values are available, and missing data becomes a huge problem. So better to do calculations than to have missing data. So we have to figure out a balance between those, and that's why calculation is still something we could do, but we just need to explicitly know that this was calculated and not coming from the source provenance. Balance bill. So balance bill is a very interesting idea that is there in the US, but shouldn't be there. It's like if you go to out of your network, then the provider is not obligated to be restricted to the allowed amount, while the third-party liability payer will say, I'm only paying a Medicare allowed amount plus a multiplier. So the physician or the provider may say, or the provider system may say, I'm going to balance bill you, patient, for the additional part beyond the allowed amount. And that's it's a very scary place for most patients in the US, because when in the time of their distress, they don't know which is their actual network and which is not, and which hospital systems and providers have agreed to the contract versus not. And even inside the same hospitals, patients have had nightmares where they go for maternity care, delivery care, but then the anesthesiologist is not part of the network, and so then they balance bill, and it's a headache. But that's a different problem, but it is an entity, it is an idea. Balance bill is an area of interest for most researchers because of all these reasons, and that's why I put that in here. Um, it's not it's a it's commonly used by health economics outcome research in academia and in health systems, less so in pharmaceutical research. But the OMOP CDM's cost, as you can see, is trying to solve multiple use cases, not just life sciences, but also healthcare. Type concept ID. So we did the cost concept ID. Now we're going to go to the provenance. So any questions of this before? Okay, we got 3 more minutes. All right. So you guys know there's adjudicated claims, and that can be represented in the cost type concept ID. There is pre-adjudicated claims. The difference between those two is mostly contractual. Some people say pre-adjudicated claims is not real care, which in many cases does not make much sense, because at the end of the day, somebody received some care, and they're not creating records out of thin air. Of course, it may not be payable by contract, but just because it was not payable by contract doesn't mean that the patient didn't receive care. So pre-adjudicated claims has its own value, but there is a need to differentiate between adjudicated claim and pre-adjudicated claim. Adjudicated claim basically means that it has gone through the payer's adjudication system, where they link the patient's benefits, the provider's rights to bill, and the agreements that's in place, and provides a post-processed data structure. Provider charge master is another source, so you could have the charge data mapped from an external source. So even though you're getting a data source that has no charge information, because you know which provider it is, or if you know which provider it is, and if you have a reference file that has the charge master, you can use that to create your charge fields. There are fee schedules out there that you can use. Again, we want to make sure that we'll explicitly say when to use it and when not to use it. Gaurav brought up the idea of the cost to charge ratio, so we have to cover that. Now, provider costing, extremely complex idea, and patient self-reported costs. Those things are also a type concept, and that's a provenance. So patients can report their own costs. So this is just our recommendations to the work group about the conventions for how to model the data, how to, from a structural standpoint, how to map the data, and how to solve various use cases from life sciences and healthcare and payer communities, research communities, academic communities. Any quick feedback, any objections? If no objections, I will have to make a forum post saying that this has been ratified.
I just wanted to mention, Gautam, I don't think, at least I could be wrong up here. Patient self-reported costs doesn't usually come up too often from a claims perspective.
No, that self-reported would come from like surveys or something of that sort. You're right.
Yeah, and then going back to your governance principles of getting it actuarially certified, just one thing is like, I know we want to support EHR databases, but if we narrow the scope just to claims for the time being, that might be better. So then maybe patient self-reported cost kind of isn't the back burner at that point. Does that make sense?
Got it. Yeah, so let's have experience with these conventions. So now we have agreed on the data model structure, but you're saying from a research use cases, let's start with supporting claims use cases, because that is 80% of the use cases anyways for health economics outcomes research, and then evolve to EHR based. Got it.
Yeah, and then like just going off what Patrick said, it's like having this be interoperable and making sure that we're able to garner the support of the government and regulatory agencies. It'd be better if we just focused on one thing we're very sure about.
Yeah, no, I agree with you. Yeah, so in the forum post, we'll say we as a committee agree with the framework, but we want to support claims based in the beginning, and then based on that experience further generalize. But as part of this proposal, we have thought about how it may generalize to electronic health record, and we think it might, but we'll test it later.
I agree.
All right, we're 2 minutes over. Thank you, everybody. Thank you for this wonderful conversation, and we will follow this up with the forum post discussions. Please pitch in your opinions. and I'm really looking forward to the next steps. Thanks.
Thank you.
Thanks, guys. See ya.